Facet and ligamentum flavum hypertrophy can cause foraminal, subarticular zone, and central spinal canal stenosis. Synovial cysts, which form as a result of facet joint degeneration, can also cause nerve compromise when they project into the spinal canal or into the neural foramen. Thecal sac narrowing can be significant, and it can be caused by epidural lipomatosis when there's this excess of epidural fat, as we can see on the sagittal T1 weighted image here. The epidural fat can be so voluminous that it can compress the thecal sac. And here we see a very small thecal sac, and all the nerve roots are aggregated within that thecal sac. The grading of lumbar central canal stenosis, as well as neural foraminal stenosis for that matter, can be subjective, although there have been attempts to standardize this. This is the system that I use. It takes into consideration the amount of CSF that's left inside the thecal sac, as well as what's happening to the nerve roots. In the normal situation, there's no stenosis. CSF is preserved, and there's no aggregation of nerve roots in the thecal sac. When there's mild stenosis, there's some effacement of the thecal sac and some effacement of CSF, although the nerves remain separated from one another. When there's moderate stenosis, we begin to see some aggregation of nerve roots in the thecal sac, and when there's severe stenosis, as in this case, you don't see any CSF between the nerve roots of the cauda equina. This is related to a large disc extrusion right here. You can also use this grading when you're assessing thecal sac narrowing due to epidural fat or epidural lipomatosis. Various scales have been proposed to grade the degree of foraminal stenosis. On the right-hand table is a scale that takes into consideration the presence and morphology of perineural fat around the nerve root inside the foramen. On the scale on the left-hand side of the table, perineural fat is taken into consideration, as well as the presence or absence of nerve root collapse or morphologic change. As it turns out, the findings that are most likely clinically relevant and may have symptoms associated with them are either loss of perineural fat in all four directions or complete obliteration of perineural fat in the fourth row of this table, as well as the presence of nerve root collapse or morphologic change. Personally, I use the table on the right, but I also mention when I see nerve root displacement or compression. That being said, it's important to recognize that degenerative changes are a normal part of aging, and that many patients will have one or more degenerative changes that can be described in MRI lumbar spine reports that are asymptomatic, and the prevalence of these findings just increase with age. Therefore, imaging-based degenerative changes must be interpreted in the context of the patient's clinical condition. So what imaging findings might matter? Things that are likely clinically important: moderate or severe stenosis, disc extrusions, nerve root displacement or compression, as we talked about before, end plate edema, which is type 1 modic change, or grade 2 or higher listhesis. As a quick recap of our search pattern, we looked at the ABCDEs of MRI spine evaluation. We can assess alignment primarily on the sagittal images and any available coronal imaging. We're looking at spine curvature as well as listhesis. We'll look at the bones or the spinal column. We want to make sure it's intact, but we're also going to evaluate the bone marrow. Regarding the spinal canal, we want to look at the epidural space as well as the contents of the thecal sac, the distal cord, the conus, the cauda equina. Then we'll catalog degenerative changes using our standard lexicon. And then, of course, we'll look at everything else, including the localizer image, the visualized abdomen, pelvis, and retroperitoneum. And last but not least, we should look at the clinical history and try to find the imaging finding that might explain the patient's symptoms.